On behalf of Mumbai Hematology Group and in TAS, I'm Dr. Manoj Kumar, Executive Vice President in TAS. It's my honor and privilege to welcome all the delegates who are going to witness two interesting presentations. And we would assure you that it is going to be a very interesting interaction worth your time. We would also like to welcome our chief guest, Dr. Shilpi Saxena. Madam, we look forward for your pearls of wisdom. All this interaction has been possible courtesy our program director, Professor Dr. M.B. Agarwal, and our program moderator and coordinator, Dr. Amit Khurana. We know Dr. Amit Khurana pretty well. He is going to be the backbone behind Hemato-Onco, which is going to happen very soon. And he's a very leading hematologist and BMT expert in Western part, and he is housed in Surat. Dr. Priyanka, warm welcome to you, and Dr. Rakul Pace, warm welcome to you. May I request Dr. Amit Khurana to take it forward from here, please?
Thank you, Dr. Manoj Kumar, sir. If you can unshare your screen. Yeah, thank you. So, well, very good evening. Well, very good morning to all of you, and good evening and good afternoon to all others who are joining from the rest part of the world. Today, there are two guest speakers. The first one is Dr. Priyanka Srivastava from Anand, Gujarat. And the second guest speaker is Dr. Renquil D. Paz from Madrid, Spain. Our first guest speaker, Dr. Priyanka Srivastava, is medical oncologist based at Gujarat, and she's going to lecture us on geriatric assessment in hemato-oncology, why it matters. And our second guest speaker, Dr. Renquil D. Paz from Madrid, Spain, who is going to lecture us on ASH update on MDS. This webinar, as usual, is brought to by Mumbai Hematology Group, supported by INTAS, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar, Dr. Anis and team from INTAS, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Shilpi Saxena from FMC Pune. Our guest speakers for the day, Dr. Priyanka Srivastava from Gujarat and Dr. Renquil D. Paz from Spain. All our discussions were themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 18th of April 2026, we have again two lectures. The first lecture is at 6:15 p.m. Indian Standard Time by Dr. Nilesh Vasekar from Nasik, speaking to us on redefining success in CML, role of asciminib in first-line CML. And following this, at 7 p.m. Indian Standard Time and 8:30 a.m. US Central Time, we have Professor Dr. Anand Patel from University of Chicago speaking to us on Beyond the Classical pH Negative MPNs. And the following day, that is Sunday, 19th of April 2026, we have a lecture on Beyond the CBC Utility of Newer Reticulocyte Parameters in Clinical Decision Making by Dr. Anjali Kelkar from Pune. Let me introduce our discussions for the day, and they are well displayed in alphabetical order. I will just pause for a while for you to look on all our discussions for the day for very eminent hematologists, hemato-oncologists, medical oncologists all across the country. So these are our discussions for the day, and now it's time to introduce our first guest speaker for the day. We all know other than Dr. Priyanka Srivastava, a medical oncologist from Gujarat. Let me introduce Dr. Priyanka Srivastava to all of you. Dr. Priyanka is MD, DNB in medical oncology, Fellow Medical Oncology, PMCC, UOT, Canada, Director and Senior Consultant Medical Oncology at Reos Comprehensive Cancer Care, Anand, Gujarat. She is a medical oncologist and hemato-oncologist working at Apollo Hospitals International Limited, Gandhinagar, Gujarat. She pursued MBBS from Medical College, Vadodara, Gujarat, and was awarded gold medals from MS University. She pursued her MBBS from Medical College, Vadodara, Gujarat, and awarded gold medals, as I said, from the MS University, followed by which she did her MD in internal medicine from Baroda Medical College, followed by DNB in medical oncology from Indraprasth Apollo Hospitals, New Delhi. She has also done a fellowship in medical oncology from Princess Margaret Cancer Center, University of Toronto, Canada. She worked as consultant medical oncologist and hemato-oncologist at MS Patel Cancer Center, which is a rural-based tertiary referral center. It is also a part of National Cancer Grid and Hospital-Based Cancer Registry Program of ICMR. She is a member for DNB Medical Oncology Program at her institute. She has received several publications in peer-reviewed journals. She is also the editor for the Gynec Oncology section of Indian Journal of Medical and Pediatric Oncology. Today, she is with us and she is going to lecture us on geriatric assessment in hemato-oncology, why it matters. And just to introduce our second guest speaker, we have with us Dr. Ranquil D. Pez from Madrid, Spain. Dr. Ranquil is attending physician for 21 years in the Department of Hematology and Hemotherapy at La Paz University Hospital in Madrid, Spain. She is currently in charge of the Hematology Day Hospital and the Clinical Trials Unit, as well as a specialized clinic for myelodysplastic syndromes and chronic myeloid leukemia. She is also the author of the Spanish Guide to MDS and CMML, published by the Spanish MDS Group, that is GESMD 2020 edition, and the Manual of Recommendations on CML, published by the Spanish Chronic Myeloid Leukemia Group, that is GELMC 2024 edition. She has published over 88 articles in national and international journals. And she's going to lecture us on ASH update on MDS. But before our speakers does that, we have our special guest and chief guest for the day. We have with us no other than Dr. Shilpi Saxena from AFMC Pune. Let me introduce Dr. Shilpi Saxena to all of you. She has been a regular attender in this webinar over many years. It's my formal duty to introduce Dr. Shilpi Saxena to all of you. Dr. Shilpi Saxena is an alumni of AFMC Pune with specialist hematology training from ACTREC, Navi Mumbai, and ICMR and IIH Mumbai. With over 18 years of service in Indian Army, she has contributed to the clinical and academic pathology within the Army Medical Corps. She currently serves as Professor of Pathology at INHS Aswini, which is specialized in diagnostic hematopathology. She has been involved in establishing flow cytometry and hematopathology diagnostic facilities at 2 tertiary care hospitals. Her areas of interest include hematolymphoid neoplasms, PNH, HLH, and immunophenotyping-based diagnostics. As a postgraduate teacher and examiner, she is actively engaged in training and academic evolution in pathology. She has authored about 22 peer-reviewed publications in national and international journals. She is also a contributing member of an ongoing ICMR-funded research project. She has also participated in collaborative research activities with IIT Roorkee, supporting interdisciplinary scientific work. It's my privilege to welcome Dr. Shilpa Saxena to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Shilpi Saxena.
Thank you so much, sir. Good morning, everyone. Thank you, sir, for the kind introduction. I am deeply grateful to MHG and especially to Dr. M.B. Agarwal, sir, for inviting me to be the chief guest. It's an honor to share a few words as we reflect today on geriatric assessment in hemato-oncology, why it matters. Hippocrates reminded us, quote, "Make a habit of 2 things, to help or at least do no harm," unquote. Let me share a brief moment from a 24-hour emergency duty where I was a senior medical officer. An elderly gentleman arrived after the regular hospital hours simply to collect his routine medications. He had traveled from a distant town and was delayed by transport. An intern, exhausted and overwhelmed, began to scold him. "Baba, you should have come earlier. Don't you know the hospital working hours? This isn't the time for routine problems." I asked the intern to pause, take history, examine the patient, get his investigations raised, and provide whatever medicines were available at that hour. We didn't change the world in that moment, but we changed that man's night from judgment to care. Here is the point: anyone who comes to the hospital is already troubled. Our words should not add to their distress. Empathy and clear communication are not soft skills. They are core clinical skills. Most of the negative feedbacks does not come from wrong diagnosis. It comes from miscommunication, misunderstanding, and careless language. We must teach our students medicine, yes, but also how to listen, how to explain, and how to dignify. This is precisely why geriatric assessment matters in hemato-oncology. Older adults are not merely older versions of younger patient. They have different physiology, reserves, priorities, and risk. Geriatric assessment shift the question from "can we treat" to more human, How should we treat this person safely and meaningfully? Our goal is not only survival curves, it is dignified survival treatment that aligns with function, values, and life beyond our wards. When we pair science with sensitivity, geriatric assessment becomes the living expression of Hippocrates' wisdom: help when we can, and at least do no harm. Thank you once again, MSG, and to Dr. Ambi Agarwal sir for this opportunity. May we continue to practice hematology that is rigorous in evidence and generous in spirit. Thank you.
Thank you, Dr. Shilpi Saxena. Wonderful words of wisdom, wonderful quotations. Thank you so much. A very well prepared speech. Thank you so much to give such wonderful words of wisdom to all of us today. And now, Dr. Priyanka Srivastava, screen is yours. Please go ahead.
Thank you, Dr. Amit. Am I audible?
Yeah, you are audible.
Thank you. I'm here. I'm honored to be here on this esteemed platform of Mumbai Hematology Group. I thank Dr. MB Agarwal sir for giving me this opportunity, and I thank Dr. Amit for giving such a wonderful introduction. I'm overwhelmed. I honestly thank Dr. Shilpi for giving such an introduction of geriatric assessment that in honesty, I feel I do not need to present this topic. Geriatric assessment does matter. So let's look into some scientific part of it. I will share my slides. Kindly allow me to share my slides. My slides visible to you all?
Yes, it's visible. Can you make it as full screen mode, please? Perfect. Please go ahead.
Okay. As my background says, I'm a medical oncologist, and in my clinic, I look after both hemato-oncology and the solid organ malignancy patients. And geriatric population makes a major chunk of the patient who comes into my OPD for their care. And hence, this topic, geriatric assessment, is very close to my heart. As a family member, I'm looking after two pair of senior citizen in my family, and I come across day-to-day challenges of the geriatric issue. So what is the geriatric age cutoff? If we look into the number-wise, United Nations says 60 years as a cutoff age for geriatric population. However, some other bodies such as World Bank and Organization for Economic and Development use 65 years as a cutoff for the old age. However, age is not just a number. The physiological important NCCN guideline highlights the importance of physiological age and functionality over the chronological age. We will look into why. The current population structure, if we look into, the majority of the world's population is made up by the younger adults and the middle-aged population. Although the geriatric population makes a smaller part of the world population as of now, it is rapidly growing. And the same thing is true for the Indian population. We are majority younger adults at present, but pretty soon we will have a boom in the population beyond 60 years of age. As highlighted here, by 2030, they will be making around 40% of our population. This is a animated diagram of how India's population is going to change in next 40 to 50 years. And if we look into clearly, we are kind of following the pattern which Japan has been following, and we are lagging behind by 30-40 years. But pretty soon we will be there where the majority of our population will be elderly and in need of special care. So why aging is important? Why understanding the process of aging is important? Aging and cancer, they share the same pathobiological features, such as alteration in cellular at the cellular level. They share the same pathobiology, like changes in metabolism, telomere shortening, proteostasis loss. There's a decreased nutrient sensing at the cellular level with the aging, and epigenetic modification. All these factors actually are contributing to the development of malignant cells as well. And hence, we see that over the years, as the population of geriatric age group has been increasing, there have been an increase in the prevalence of cancer in the age group as well. However, for some known and some unknown reason, this growth in the prevalence of cancer in the elderly group has been more pronounced in the developing nation compared to the developed nation. And one of the article, it is projected that by 2035, lesser developed countries will see a plus 144% increase in the number of older adults living with the cancer compared to 54% increase in the developed nation. And same is true for the incidence of myeloid and lymphoid malignancy. They increase with age, peaking at around 75 to 99 years of age. Most of the hematological malignancy have a median age of presentation in 60s. Certain malignancy have a bimodal presentation as well. Universally, all over the world, the outcomes of hematological malignancy and particularly the aggressive malignancy have been dismal with the each passing decade of life, whether it be a multiple myeloma or acute leukemia. In both treated as well as untreated patient population, they perform very dismally. One very important factor which comes across in the clinical practice is that in clinical trials, the geriatric patients are frequently underrepresented. In 2017, Kanapuru et al. Published a very nice article about this discrepancy of elderly age patients representation in the benchmark clinical trials which were done for the FDA approval of the drugs. They looked into the hematological malignancy, namely CML, CLL, multiple myeloma, and lymphoma. And a common pattern was that compared to their representation in the CR data, the representation in the clinical trial was compromised. And especially for patients more than 75 years of age were consistently underrepresented in the trials of lymphoma, CLL, CML, and multiple myeloma. For example, if we look into the CR incidence of CML in patients more than 75 years of age, it happens to be 28.6% versus in the clinical trial, the representation is only 3.8%. So basically, the senior citizens are systematically removed from the benchmark clinical trial for some or the other reason. Most of these clinical trials have exclusion criteria of frailty as well as in the comorbidities. These comorbidities are very common in the senior citizens, and that's why they do not qualify for the enrollment in the clinical trial. So what happens is that we are following the data which was established in the relatively healthier and the younger age group and try to extrapolate these data to a more frail population of the higher age group. And that's why we face a very unique challenge when we are managing the geriatric patients in our clinical setup in a real world setting. So this comes to this brings us to the topic of frailty. Frailty is a word which is very interchangeably used between the older age group and with the older age group. It is a term which was derived from the Latin word named fragilitas. Basically, it represents a subset of patients who are weaker and more vulnerable than their age-matched counterpart. First mention of word frailty is seen in an article published by O'Brien et al. In 1968. Where it was used, the term was used as frail and elderly to describe a heterogeneous group of individuals. In 2001, in their cardiovascular health study, Fried and et al. Basically provided a more structured definition of frailty. It is basically a clinical syndrome which is based on the presence of 3 or more out of 5 criteria. They included unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, and low physical activity. Well, by definition, frailty is not elderly, but if we look into the proportion of frailty in elderly population, it is much higher compared to the relatively younger. So these both terms are basically used in as an interchanging words. So what is geriatric syndrome? Geriatric syndrome is a term which is used to describe a unique health condition in elderly patient. It is multifactorial in cause, and it does not fit into any discrete organ-based category. Geriatric syndrome has both component, both as an internal as well as external environment component. If we look into the internal component, it will include the physical health of patient, that is comorbidities, nutritional status of the patient, kind of medications they are taking, their emotional health, their cognition health. Then external environment will include their social support, that is caregiver support, financial burden, and as well as their mobility and functioning around the house or in the community. There's another very unique challenge while we are caring for elderly patient is that drugs will have a different kind of have different pharmacokinetic and pharmacodynamic changes along with the aging population. As we age, there are changes in our body which will alter how we treat the drug. That is your pharmacokinetic, that is absorption, distribution, metabolism, and excretion. All four steps of the pharmacokinetics are altered with the aging. For example, in the drug's absorption from the GI is altered owing to the changes in the gastric acid, pH, mucositis. There's a tendency of delayed emptying. The multiple drugs consumed by the elderly population, including the PPI and opioid, will change the drug absorption, oral drug absorption. The distribution of drug in the body also changes with as we age. There are increase in the body fat. There's decrease in the muscle mass or sarcopenia is there. Total body water reduces, albumin reduces, and increase in the alpha glycoprotein. These all factors affect the drug's distribution inside the body. If we look into the metabolism, phase 1 metabolism gets affected. However, phase 2 metabolism remains relatively preserved. Polypharmacy changes the liver CYP mediated metabolism of the drugs. Excretion is very important, and in elderly age, we see there is with every passing years of life, our renal blood flow goes down, GFR decreases, and the tubular secretion decreases. Pharmacodynamic changes in elderly are less clearly defined. However, some factors are very well known. That, for example, there is a changes in the receptor sensitivity. Older adults appear to have higher sensitivity of the certain drugs as compared to the younger population. When very common drug which we use as a medical oncologist in our day-to-day practice is 5-FU or capecitabine, and we have seen that these patients have very severe diarrhea as compared to their younger population. So there is definitely a change in the sensitivity to drug, and we do not know the OBD for this subgroup of patient. Second, what we see in older patients that there is a very severe and prolonged cytopenia that can happen because of the reduced bone marrow reserve. These patients have compromised cardiac, hepatic, renal, and neurological reserves, and we do not know what is the maximum tolerated dose, particularly to this age group. So how we can reduce the patients, how we can reduce the burden of adverse drug reaction while successfully managing the primary disease. And that's where the geriatric assessment and management comes into the picture. So basically, the current recommendation is that every elder patient, every senior citizen patient should undergo a comprehensive geriatric assessment prior to their treatment planning. Earlier, only one hematologist would be involved in the care, and then they will take the decision what treatment they want to offer. But as more and more comorbidities come into the picture, multiple referrals get multiple specialists get involved in the care of elderly patients, for example, cardiologist, nephrologist, and there is a definite need for a geriatrician or geriatric physician in the management of these patients as well. Palliative care physician is also one of the very important pillar in the management of these patients. As a medical student, we are taught to do a performance status examination at the when we see the patient as one of the vital sign. However, ECOG performance status is not enough for this group of patient. If we look into this study by Kleppin et al., the various domains of geriatric assessment were found to be affected in the patients with acute myeloid leukemia, even when they were having a ECOG performance status score of equal to less than 1, ranging from around 25% to up to 53%. So only ECOG performance status or KPS performance status is not enough for deciding the treatment in these patients. So what are the domains of geriatric assessment which we need to assess? This include the functionality and mobility that can be tested, that can be assessed using the various tools available like ADL and IADL. History of falls is very important in elderly patients. Recent history of multiple fall is basically an indicator of poor outcome. Gait speed. It can be tested as a 4-meter walk and noting the time and then calculating the gait speed. Time up and go is a very easy test which can be performed in the office. Getting up from the chair, walking for 3 meters, coming back and sitting on the chair again. The time up and go, if it is more than 20 seconds, portend a poor prognosis for the geriatric patients. There are multiple comorbidity index as available. For example, Charlson comorbidity index. Social support is very important for geriatric patients. There are questionnaires available easily and free to use. For example, MOS social support survey. Cognition is one of the very important domain of geriatric assessment. It affects the survival in patients, and we can do a full-fledged assessment, that is MMSE, or a short form like mini-cog can also be performed. Many times geriatric patients suffer depression, which may be masked. When we take a proper history or assess on the established tool like GDS, these masked depression can become overt, and it will be very helpful if we can address these issues in the patients, and it will improve the outcome. Coming to the nutrition, as an oncologist, we know that nutrition is a very important part of the management. However, if we look into the BMI only, it may not give us the full picture. Mini nutritional assessment, MNA, is a very important and validated tool which takes into consideration the recent weight loss as well as appetite and cognition and depression as well. Polypharmacy, that is consumption of more than 5 equal to more than 5 medication on daily basis, is very prevalent in geriatric population. Some of these drugs are prescribed for their comorbid condition like diabetes, hypertension, coronary artery disease, dyslipidemia, which are very common in this population. However, on an average, patients consume multiple over-the-counter as well as the alternative medicines which affect the treatment outcome in these patients. So activity of daily living forms like CAT's basic activity of daily living form is available, which scores the 6 domain of the daily activity. If scored high, that represent that patients are independent in their daily activities, while the lower the score, patients are more dependent. Lawton instrumental activity of daily living scale evaluates 8 domains, and so when we see a patient with the senior citizen category patient in our OPD, the current recommendation is that we employ a geriatric assessment screening tool. There are a list of geriatric assessment screening tools which are available, and a couple of them have been thoroughly validated in the hematology patients as well. And if there are any deficit found on these screening assessment, we should proceed with the comprehensive geriatric assessment. Geriatric 8 screening tool was basically developed by the French group, Valera et al. It basically included 364 patients who were 70 years of age. In this in their validation cohort, development and validation cohort, 30% patients of NHL were also included. So in hematological malignancy, Geriatric 8 has been, we can say that it has a performance. They basically, the total 8 points are assessed, including the food intake, weight loss, mobility, psychological issues, body mass index, polypharmacy, and self-reported health, and they are weighted against the age. So total scores goes from 0 to 70, and the score less than 14 is basically considered as an impairment. So if we look how this cutoff is basically formulated, so whenever we are employing any screening tool, we should have a very high sensitivity so that no false negative patients are detected. It would be ideal to have a 100% sensitive test, but we know that as the sensitivity increases, specificity goes down. So we need to have an AUC curve where the sensitivity is high, but specificity is also at a acceptable level. So if we look into this ROC curve, at the 40 cutoff value of G8 at 14, the sensitivity estimate is around 80 with the specificity of around 65. So at this cutoff, we will be able to screen the patients who will require the comprehensive geriatric assessment. Another self-reported form which is available for hematology patients is Vulnerable Elder Survey 13, VES 13. It evaluates 13 domains, and it is basically a self-reported form available. It is easy to use, and it can be completed within 5 minutes, and it does not require clinicians' support. Patient can fill it up on their own. It can be rated as a continuous score, or it can be used as a binary outcome where the score of 3 basically identify a vulnerable adult. Now coming to the comprehensive geriatric assessment tools available for the hematology patients. Excuse me. So GAH, Geriatric Assessment in Hematology. GAS scale was basically developed as a 30-item scale. It is a multi-step process. It covers around 8 relevant dimensions. It was basically designed and then validated for the patients aged more than 65 years of age, newly diagnosed with the validation study included 4 hematological conditions, that is MDS, AML, multiple myeloma, and CLL. Authors reported that mean time to take this comprehensive assessment was around 15 minutes. Again, it includes the 8 domains of geriatric assessment, that is polypharmacy, gait speed, mood, activity of daily living, patient's self-reported health status, nutrition status, and mental status and comorbidity index. It's a validated tool in hematology, and it can be used for geriatric patients, newly diagnosed geriatric patients who are proceeding with the treatment. So to validate that predictive value for the treatment tolerance in geriatric patients, the same group further validated this tool in a retrogas study in which around 126 patients from the same patient cohort were further analyzed. And these patients were to receive standard frontline treatment. No dose adjustment or delays were. The patients who required dose delay or dose adjustment were excluded from this. So again, now we need to formulate an optimal cutoff. So at the optimal cutoff of GAH score of 42, the test maintained a 68.5% sensitivity and 55.8% specificity. At this cutoff, in this population, 66% patients developed some form of toxicity, and the AUC was 0.6. The authors concluded that this scale enables clinicians to individualize therapy based on risk of toxicity. At 42, we can say that 66% of the patient will have some sort of toxicity. During the development phase, the univariate analysis showed that all the factors of the geriatric assessment were important for the survival. However, for the treatment-related toxicity, however, on multivariate analysis, gait speed, activity of daily living, and nutrition maintain their statistical significance. Some diseases, we have a disease-specific geriatric assessment tool also. Multiple myeloma is one disease which presents in the elderly age group. A thorough work has been done in assessment of fitness in multiple myeloma or frailty in multiple myeloma. It is said that in coming decade or so, there will be almost 80% increase in the patients who are more than 75 years of age. Also, the treatment of multiple myeloma has changed and improved a lot in last decade with the introduction of monoclonal antibodies. And we need to basically have an idea whether we can go ahead with the 2-drug, 3-drug, or with the transplant in this population. Elderly prognostic index has been developed in the aggressive NHL for aggressive NHL patients. So let's look into the myeloma patient. So International Myeloma Working Group presented their, under the guidance of Palombo et al., presented their report of around 869 patients from 3 prospective trials. They basically included the 4 parameters, that is age, Charlson Comorbidity Index, activity of daily living, and instrumental activity of daily living. And based on that, patients were reported to be fit to intermediate fit to frail patients. The distribution was around 40%, 31%, and 30%. Patients who were fit perform good. Patients who are frail perform worse in all the parameters, including the overall survival, their hematological and non-hematological ADRs, and progression-free survival. If we look into the univariate and multivariate analysis, the fit patients do better compared to the frail patients, and if we adjust them for ISS and chromosomal abnormality, this difference become more pronounced. For example, the hazard ratio for in the adjusted group, if we see the survival from the hazard ratio goes from 1 to 2.88. The grade 3 hematological toxicity is not statistically different between these groups. However, grade 3 non-hematological toxicity is more pronounced in frail patients compared to the fit patients. Second, very widely used and prognostic index for elderly patient is revised myeloma comorbidity index. It's basically it includes 5 factors, the maximum score of 9, developed by Engelhardt et al. It basically includes the renal dysfunction, lung dysfunction, KPS performance status, age, and frailty. They initially included the cytogenetics, but later on multivariate analysis, the cytogenetics was not so convincing. So this is given as a plus or minus. Definition of given by the Fried et al. Was used for the frailty, that is presence of weakness, and low endurance, low physical activity, slow gait speed and shrinking. Presence of 2 factor was defined as a moderate frailty, and presence of 3 factor as a severe frailty. On their validation cohort of 249 patients, revised RMCI performed very well. If we look into the hazard ratio, the difference in the hazard ratio when we see the patient fit versus intermediate versus frail, it goes up to 28. As compared to the other comorbidity index, which is the difference is not so pronounced. In an article published in 2019, written by Scholes et al., in which they compared basically the 5 comorbidity indexes which are currently available for multiple myeloma patient, revised myeloma comorbidity index performed very well. And basically, it can predict the 3 years overall survival, 3 years progression-free survival. The difference in the retrospective and prospective comparison data, the difference was not statistically significant. So it can be performed in the both subset. It is quite time effective. These 3 indexes, that is revised RMCI, International Myeloma Working Group, as well as Charlson Comorbidity Index, are available as an online tool, very easy to perform. This is the website where students can actually access this calculator. You just have to put the data currently available to you, and you will get the survival curves where patients can be consulted and the treatment decision can be made. A recent article published in Blood Journal 2024, How I Treat Multiple Myeloma, faculty et al. Basically evaluated the key fatality scores which are currently available for clinical use. And although earlier the clinical trials, they do not segregate or made a subgroup of frailty patients, they had some significant number of proportion of these patients. The further subgroup analysis suggests that the overall survival is lower as compared to the more fit patients. The thing which we should keep in mind that these patients were basically evaluated in the clinical trial setup where the fitness and the age sometimes is biased. In current multiple myeloma clinical trial and management, daratumumab has become a backbone and has revolutionized the outcome of the patients with myeloma. And now more and more clinical trials are basically reporting their subgroups of frail patient. It can go from 45 to 100% of the patients in the different clinical trial. Daratumumab performs maybe the response-wise, the performance progression-free survival and the overall survival may be matched as compared to the regular population. However, grade 3 treatment-related adverse events are higher as compared to the more fit and younger patients. Next, aggressive malignancy, which we see in the elderly age group, is diffuse large B-cell lymphoma. So, Spena et al. Under the FIL group developed a simplified comprehensive geriatric assessment using the CIRS, that is Cumulative Illness Risk Score of Geriatrics scaling. Basically, it includes 14 diseases, out of which are graded from 0 to 4, depending upon the severity of those illnesses, and the scores are given. So these patients can be divided on the basis of their ADL score, IADL score, and CIRSG scores into the fit, unfit, and the frail. That is your simplified comprehensive geriatric assessment for aggressive lymphoma. Further, when we add age into this was divided into 3 group, risk group, that is group 1, depending upon the age, that is less than 80 or more than 80, group 2 and group 3, that is more than 80 years, and the frail on the assessment. On multivariable analysis and the relative weight of independent covariate, they built an EPI score, giving the weight marks to the each score, that is from 0 to 3. The cumulative scores were further evaluated in their training set as well as in the validation set. Here we see the blue line, which is the cumulative score of 0 and 1, is doing better compared to the scores of 2, 3, and 4, which is presented here as an orange dot. Patients who had a cumulative score of EPI in the range of 5, 6, and 7 had a very dismal outcome. So this study basically tells us whom to treat, with how much aggressive we can go for their treatment, because the patients with the highest EPI score will have a dismal outcome irrespective of the treatment selection. VES 13, vulnerable patients can be, we can basically screen the patients with the VES 13. It has a very good sensitivity and for predicting the death within first year of treatment, going up to 100%. These patients will be found, if we assess the frail patients on FILGA assessment, 100% patients, so that there's a quite match if in this section. However, for the other parameters like predicting the grade 3 non-hematological toxicity or unplanned hospitalization, decline in QOL, and death or progression within 1 year, screening tool perform less as compared to the comprehensive assessment. CLL is one disease where we have scale score and creatinine clearance based on the Cockcroft-Gault formula. They evaluated the targeted therapy and chemoimmunotherapy based trials. The final recommendation was they divided the patient into fit, who had the lower CIRS, that is less than 6, and better creat clearance more than 70. These patients can be offered both chemoimmunotherapy as well as the ibrutinib BTK inhibitors, while the patient who are unfit, that is CIRS more than 6 and creat clearance 70, less than 70, have poor tolerance to the monoclonal antibody rituximab. Last few slides about the CAR T-cell therapy. We know that CAR T-cell therapy has revolutionized the treatment of hematological malignancy, and many times we have eligible patients for the for these treatment in the older age group as well. So worldwide, the older age group patients are being assessed for the CAR T-cell treatment. They are proceeding with the CAR T-cell treatment. Their outcomes may be less as compared to the relatively younger population. In an article by Richard et al., they evaluated lymphoma patients who underwent CAR T-cell therapy, the role of early geriatric consultation. These patients, even though they had a good performance status at while the enrollment in the study, a significant proportion of the patients showed a deficit in their geriatric assessment. And this was most pronounced for the impairment in the cognition. And the overall survival in the patient who had no cognitive impairment was much better than the patient with a cognitive impairment. Early geriatric consults help patients in terms of their overall survival beyond 1 year. Although the progression-free survival was not different in whether we get done the geriatric consult early in the care or not, overall survival curves separate after the 1 year mark. Management of toxicity of CAR T-cell treatment. If patients have geriatricians involved in their care from day 1, they have a better outcome. For example, the ICANS all grade was statistically significant in statistically significance higher in patient who did not have a geriatric consult at the beginning. Another article by CIBMTR group published shows the outcome of patients less than 70 years or more than 70 years, and treatment-related mortality and overall survival is not statistically significant. However, progression-free survival and the relapse appear to be worse in age more than 70 years of age. So CAR T-cell treatment, age is no bar. If patients are selected are properly and their early geriatric consultation is done, they may have a similar outcome as compared to the younger population. There are few geriatric assessment tools available for solid organ malignancy. They are available as a calculator on the apps as well, for example, MedCal. And we commonly use CARG and CRASH, and CARG breast cancer is also available. They have been validated in the hematological malignancy. The CARG development phase did not have any hematological malignancy patient, and it is not predictive. So we cannot basically use to predict the hematological toxicity in hemat patients. Versus CRASH, the validation cohort of the CRASH scoring, they were around 15% NHL patients were there, and CRASH score also includes some lab parameters, that is creatinine, albumin, hemoglobin, LDH, and LFT. And in one of the study, Ortland et al. Evaluated the performance of CRASH versus CARG in hematology patient, and the CRASH performed good. It was predictive of in the hematological patients, while the CARG was not. So having said that, that geriatric assessment is important. It is mandatory for the treatment, holistic treatment of this population. But there are several limitations of this assessment at present. First, most important, in a low LMIC in a OPD where a heavy number of patients are seeing on the daily basis, it is time constraint. It requires average from 15 minutes to 30 minutes for geriatric assessment. And second is that it is not a one-time assessment. Geriatric assessment parameters may change over the time as the patient progresses with the treatment. These things can change. So it has to be a continuum of care. We do not have a robust biomarker and hence we cannot compare the data. There is a lack of training of healthcare providers. Sorry for the spelling mistake. At present, we hardly have any geriatric oncology fellowship present in our country. At present, I'm aware that there are geriatric MD courses are being provided in the one of few of the very esteemed universities in India, and AFMC is one of them. Validation in the specific population is needed. So far, whatever I have presented has been validated in Western population. We do not know what and how these geriatric assessment tool will perform in our patients. Some geriatric assessment scores, they do not individualize the specific scoring, and some drugs may have a very specific organ damage. For example, anthracycline causes cardiac toxicity. And they are very important part of the treatment in acute hematological malignancies. So what is the way forward? We need to educate, we need to do partnership, we need to do more research, and we need to incorporate these data into our daily clinical practice. I would briefly like to represent my data, which it is a part of the geriatric assessment study we performed in our hospital setup as a part of our research. It included 150 patients of solid organ patients who were treated with a curative intent. Geriatric assessment was done at the baseline. At univariate analysis, all the parameters were statistically significant. However, in the multivariate analysis, male gender, history of fall emerged as one of the important parameter, and patients who were not able to complete their planned chemotherapy cycles have burst out. So on a Monday morning, when fellows go back to their busy OPD, I would like them to memorize these 4 M. That is, when you are taking care of a geriatric patient, you should look into these 4 M's. That is, what matters to patient, what medication they are on currently, what is their mentation status, including dementia, depression, delirium, and what is their current mobility status. If we take a note of these 4 M, the majority of the geriatric assessment domains will be covered. And with this, I would like to finish my presentation. And my take-home message is that the geriatric assessment in hemato-oncology, it matters, and we must pay some attention and extra time while we are taking care of these patients. Thank you.
Thank you, Dr. Priyanka. Wonderful lecture. Let's start our question session with Dr. Priyanka Srivastava. Yes, Dr. Babita Swadi, ma'am, please go ahead. You're muted, ma'am. Please unmute yourself.
First of all, thank you very much for having me on this platform. And Dr. Priyanka, thanks a lot for the comprehensive talk. Agreed that there is no second thought to it, that there is the elderly patient calls for the coordinated, integrated, and the systematic approach for the older patients, focusing not only on the comorbidities, but also on the functionality and the social support and the nutrition. My question to Dr. Priyanka is that what is your approach when the geriatric patient, when the older patient is encountered in hematological malignancies, especially the AML, with the on with the that opportunistic infections, that is the other than the rare opportunistic infections, for example, say atypical mycobacteria. What is your approach and what is your comment on this?
Thank you, ma'am, for asking a very important question. So infections and elderly population, they go together, and especially when we are taking care of acute myeloid leukemia patients. And these are one of the main reason why we do not treat acute myeloid leukemia so aggressively in the elderly patients, because they sometimes present with a life-threatening infection. So first of all, we should, in my approach, we should make a point to see whether the patient is frail in general, or this frailty is because of the acute event, that is infection. If after control of the infection, patient shows an improvement in their general condition, we can go ahead and discuss the holistically with the patient's family, what are the treatment options available and what are the outcomes parameter which we are looking at. So most important part is that we should not on day one disregard the fact that we can offer some form of treatment to these patients. We should treat the acute condition, acute infection, acute hematological manifestations first, and then take a stepwise approach towards the treatment decision.
Okay, thank you.
Thank you, Dr. Babita ma'am. Any other question, Dr. Babita Sodi?
That's all, sir.
Okay. Dr. Priyanka, should I ask you one question? If in terms of diffuse large B-cell lymphoma or any other aggressive lymphomas, basically, it's very difficult to choose which protocol to give to the patient, because if any elderly patient do come, basically, some patients of elderly are very fit. There are some patients are unfit, some patients are frail. So with too many tools we have, we are not able to choose what tools is the best tool actually. So any one OPD tool which you can suggest that this can be the best tool, and if it is there, and if it fits into the patient's criteria, in the fitness criteria, we must apply this in terms of fitness. So one tool after all the tools what you mentioned, basically, and one tool in the OPD setting for day-to-day practice, which you will address to all of us.
So good question, Dr. Amit. While preparing for this presentation, I also came across so many tools, and I actually looked into what could be the best option available. So EPI, which I presented here, is one of the very validated tool available to us. And it includes the cumulative illness risk scoring, which is again available online. So this can be performed very easily online, and it will less time consuming. They will further divide the patient between the fit, intermediate, and the frail patients. And when we add age to it, we can categorize these patients into group 1, 2, and 3. So group 1 patients are basically fit and relatively younger, in whom we can offer anthracycline up to the 70% of the dose which we are planning. Patients who are intermediate will require some dose reduction, like as mini CHOP. Patients who are more than 80 years of age and overtly fail are not a candidate for a very aggressive treatment.
Thank you. Regarding the chronological age versus biological age, what you will choose out of the two when you're putting into the criteria?
So yes, chronological age is important, but the biological age scores higher. So 80 years is taken as a cutoff.
Thank you. Another question has been raised by Dr. Yimon Tent. What biomarkers, for example, sarcopenia via imaging, inflammatory markers, complement CGA testing?
So in the CGA, one CGA I presented where in a solid organ, in the CASH score, where we use some of the blood parameters as well. Hemoglobin, albumin, LDH are the parameters, hematological parameters, which we use commonly while making a decision. Sarcopenia is a very important concept which is coming up. As I mentioned, that body undergoes a change as we age. The muscle mass reduces and the fat portion increases in our body. And elderly people who are not exercising on the regular basis, who do not maintain their protein intake, they suffer more loss of muscle mass or the sarcopenia. There have been studies that on the cross-sectional CT scan imaging, we can actually calculate the muscle mass at the level of lumbar vertebra, and it has been actually correlated with the outcomes. The study was done in the colon cancer patients, and it did actually predicted the worst outcome of the colon cancer patients, including the albumin and the basically the muscle volume, which was calculated on the CT scan in colon cancer patient. And it did predict the outcomes, including the ICU hospitalization post-surgery.
Thank you. Another question is regarding the GA assessment tools. We have got 3 domains, for example. We have got one is functional status, right? Second, we have cognition, and third, we have comorbidities. Out of these 3, functional status, comorbidities, and cognition, which is important out of all this?
All 3 are important. All 3 are equally important.
Thank you. I want to ask regarding one question regarding acute myeloid leukemia now. If suppose you are treating elderly AML, you covered in your talk also. In elderly AML, does in elderly AML GA guide the decision making that this patient should do intensive chemotherapy versus EZA+1?
So as of now, in general, when we see a patient beyond 60 or 65 years of age, we do not go for aggressive treatment in AML. We know that they universally have worse outcome. So it is one disease where the age have been maintained as a decision-making thing. But again, I would say that many times the decline in their performance status is related to the multiple factors, including for example, anemia. So AML patients frequently have anemia, and that causes a decline in their performance status. So for example, if you have a relatively younger patient, say between 55 and 60 years of age, who has a poor performance status, appears to be frail, for some correctable deficiency, if we can correct them, we treat the acute infection, we treat the anemia, we make their environment more suitable for the aggressive treatment, we take care of their nutrition, we can treat more and more patients with an aggressive treatment in relatively younger age group. However, beyond 65 or 70 years, all of these patients are basically, they become not a candidate for an aggressive treatment.
Thank you. Another question is regarding multiple myeloma, where we all have a problem in day-to-day practice, whether to take this patient for transplant or not. Is GA helpful in deciding the patient for role of transplant in multiple myeloma?
So again, the age as a factor have been removed recently. The word says whether patient is eligible or non-eligible for the transplant. So how we decide the eligibility is based on the comprehensive geriatric assessment. Now, if one slide I presented where the 5 indexes were compared, they were basically based upon the frailty of the patient. And the frailty is something which includes the age along with the other domain of the geriatric assessment. So if patient is older in age, but still fit, we can consider them for the transplant. We can counsel them about the outcomes. Another thing is that they can be treated successfully with the 3-drug protocol. The relatively fit patients, although they are in the elderly age group, can be given with can be offered a 3-drug protocol, and they do equally good. So a myeloma is one place where the age as a criteria is becoming less and less important. Frailty is very important.
Thank you. Dr. Nikhil Kumar, your question.
Fantastic lecture. Thoroughly enjoyed it. You comprehensively covered geriatric assessment for all of us. Continuing on the last question, as far as myeloma is concerned, most patients fall into the geriatric age group. So is there any specific tool that you use in your day-to-day clinical practice to decide on initial treatment, 3-drug versus 4-drug? And once we do a geriatric assessment at baseline, how often should it be repeated in their course of treatment?
So I'm glad, Dr. Nikhil, that you raised this question. I would answer the second question first. The geriatric assessment should be done every time. Actually, as I mentioned, it is dynamic. It is not a one-time assessment. It is like taking TPR, BP, vital sign every time. So these domains will change. patient, a fit patient after 4 cycles of therapy can become frail. So it is not like at the beginning, one frail patient will remain frail throughout. He may be frail because of the disease burden. He may become relatively fit after a couple of cycles. So these the geriatric assessment domains are basically dynamic. They are not one-time assessment. Second, the first question you asked, which one to do? I would say do at least something which you are comfortable with. You have a knowledge about it, and you can perform it with less time consumption, as in the busy OPD. Doing geriatric assessment for every patient every time may be very hectic. Online tools are available. I showed one of them. Revised RMCI tool is can be done very easily. Within a second, it will give you the result. So get accustomed to one tool, and preferably which is available online, and you can incorporate into your daily practice.
Among the tools which you mentioned, is there any specific geriatric assessment tool which is tailor-made or which has been standardized on Indian patients?
So unfortunately, as of now, we do not have Indian-made tool. Like I presented my own data analysis. We did, and we found that the history of fall and male gender performed worse as compared to the other subgroup on multivariate analysis. However, all the domains were important on univariate analysis. Our study was only on solid tumor patients. We did not have a hematology patients. These all patients were curative intent patients. None of them were metastatic disease patients. So we did a very focused study on a certain group. So right now, we do not have an Indian guideline per se for hematology patients. But definitely, if you are interested, my colleagues from all over from India are interested, we can form a collaborative group. We can collaborate our data, look into it retrospectively as well as validate it prospectively, and design our own GA assessment tool.
Absolutely.
That would be
that would be
question.
great. Thank you.
Thank you. From the same note, what Dr. Nikhil asked, for example, in a case of multiple myeloma on GA assessment, your GA assessment, if the patient is frail, you declare that patient is transplant ineligible. After 4 cycles of, say, for example, DARA VRD or whatever drug you are giving, whatever protocol, the patient becomes fit. According to your GA, can your treatment decision change from transplant ineligible to eligible now?
So I would look into which, because of what parameter patient was frail at the baseline. If it was because of the multiple comorbidity, or it was because of the polypharmacy, what was the basic reason for the frailty in this patient? Like I mentioned, that comorbidity index are important part of the frailty assessment. And if the patient is having some cardiac issue, for example, patient had suffered MI in recent past, he will score higher on the comorbidity index. So this patient, although is moving around, driving his car, but the risk which was portended because of the acute MI in the recent past will remain there. So this patient will remain transplant ineligible because of the higher mortality due to the comorbid conditions.
Thank you. There was a talk in ASH in last year, December 2024, regarding the geriatric assessment. And this was basically on lymphomas and myelomas. They had mentioned about the 6-meter walking distance test, which you can do in OPD basis. It is one of the best and very useful. So do you have any idea about this, whether the patient is walking about 6-meter distance when you ask the patient to move in OPD for 6 meters, and the patient is able to do it very nicely in your OPD, that is granted as fit?
So you can basically, the test is the gait speed. You can make you can have a clock with you and ask the patient to walk. You can design whatever you want, like 4 meter or 6 meter. Ask them the walk and see how much second they take, and then you calculate their gait speed. Some clinical studies have 4 meter walk, and some studies have 6 meter walk. Depending upon the how much second, you can basically calculate their gait speed. For example, 4 meter walk. So every 0.1 meter per second decline in their gait speed is associated with the worse prognosis, worse outcome. So basically, it's a very easily available, very less time consuming test, which we can do for our patient to see what is their functional status. Another very interesting test, which we included in our geriatric assessment patients, is time up and go, which I mentioned, that the getting up from the chair unassisted, walking 3 meters, coming back and sitting again. So if the score is less than, yeah, so score in this, we take the patient has to get up and sit again. That is also included. So not only walk, the time to sit and get up again. So in this test, if it is less than 14 seconds, patient has an excellent performance status and an excellent functionality. Patient who take more than 20 seconds are considered to be compromised.
Thank you. Dr. Sorry, ma'am, your question.
Sir, that Dr. Priyanka, that assessing the, taking care of the general falls and this thing, that is all right. But specifically speaking, they are more prone to the drug toxicities. And then you have discussed AML also, that my query is that is there in the all one-to-all malignancies, dose adjustment is a different thing. But is there the less dosage adjustment to start with in the initial cycles also in the each and every malignancies? What is your approach in regarding this?
So, ma'am, general principle of pharmacology is that with every 15% decrease in the dosage, we are basically compromising the drug efficacy. So if because of the background condition of the patient, we are going 8% or say 70%, if we are offering a patient less than 70%, we are basically doing no good to the patient because of the general principles of pharmacology, the efficacy will go down.
So what should be the approach then? What should be the, because they will not be able to tolerate this much, the same dosage. So what is the, a fix, what to do, what not to do, that it should be the 85% of the, first of all, in the all, yes or no?
So I would, my approach would be, if patient is fit and acute myeloma, AML patient who is relatively younger and fit, I would like to stick to the full dosage. If not, not going beyond 85%. If patient is frail and elderly, we will treat with them less intensive treatment rather than reducing the dosage. And opinion of other experts are also welcomed here.
Actually,
how you approach
has been asked by
Dr.
The same question has been asked by Dr. Civil 10 also. Does any assessment give you any idea regarding dose reduction or not to give any treatment to the patient? I think there is nothing in the, it's just about the frailty part, right? So whether to give treatment, whether not to give treatment, whether reduce a dose, actually nothing has been mentioned in any of the tools what we have. It is just that we are just assessing the patient with the frailty part, how frail the patient is. And it is up to the clinician, and it is up to the clinician basically to decide whether this patient is able to get this or not. So
right, thank you.
So it is all up to the individual decision, case by case, and it is an individual physician decision now. So he or she can calculate the frailty score, and if found that patient is frail, better reduce the dose or do not give treatment. That is upon the physician decision. It can be subject to variation also. Some may feel we can give, some may feel we may not give. That can be the thing, right? So it is all individual decisions, I think so.
Right. Thank you.
Yeah. So any other question? Dr. Shilpi Saxena? Yeah.
Thank you, sir. I just wanted to share one case which we encountered recently. One 91-year-old male with leukocytosis. He was absolutely fine, walking patient, OPD patient. On CBC, he was found to have leukocytosis. Peripheral blood smear showed blasts and abnormal promyelocytes. We gave a suspicion of acute promyelocytic leukemia on morphology, and the sample was also sent for PML-RARA. ATRA was started. PML-RARA was positive, and but unfortunately, the patient ended up in differentiation syndrome and could not be revived. It happened within 48 hours of starting the therapy. So have you encountered any such patient of APML more than 85 years of age, and any specific recommendations for such patients?
Yeah. So Dr. Priyanka would answer that.
I have not encountered 85 and above
Yeah,
AML
I think it
patients.
was a very unusual for us also. So
I have not treated very senior citizens with acute myeloid leukemia with therapy. I tend towards the supportive care more.
I had encountered one such patient, but the patient was 75 plus, not 85 plus. And that patient was, on looking wise, patient was very fit. But when the patient was initiated with ETRA, because patient was high risk with a high WBC count, so a patient was given ETRA plus donomycin as per the protocol. Unfortunately, the patient went into differentiation syndrome, and we couldn't treat the patient.
so
Now, then I found out some of the literatures basically whether they are more likely to go for differentiation syndrome or not. Number one, whether they are more likely to go for coagulopathy or not. Number two. So there are some case reports available where they've seen that if you are treating the patient with APML in elderly patients who are more than 75 years of age, they are likely to go for more for differentiation syndrome. So a little bit, you should be very cautious regarding such patients. And plus, there is a high chance of coagulopathy, which is subtle. In the sense, basically, if the patient has got just a mildly deranged PT, INR, APDT, or just decreased fibrinogen, this patient can go into this a subtle coagulopathy. It may not be grossly altered, but they can bleed to death because they've got high chance of differentiation syndrome also, and they've got high chance of severe bleeding manifestation, even if there's a patient has a subtle coagulopathy also. So that is all because of the years of age, which we must be very cautious about. That's all. So they do not behave as simple as what we are seeing in the younger population. So this can happen, yes. And it happened to me, the same thing. That's why I had to go back to read so many articles. And it has been mentioned in those that we must be very cautious regarding elderly patients who are having acute promyelocytic leukemia because they can go into very severe bleeding manifestation because of coagulopathy. Number one. Second thing, they can go volume overload because more of FFP or transfusion, prophylactic FFP transfusion also, their heart is very conservative. They can take this burden of FFP plasma so many times. So that is a second point. And third, they are very prone for differentiation syndrome because their lungs are compromised. And moment they start differentiating, it all happens immediately. One question has just come up from Dr. Ali Mahmoud Dinky. Yeah, do we recommend adding dexamethasone in patient of APML? I think the question started with APML only now.
Yeah, so they had mentioned the earlier comment says the starting the arsenic first and then adding a low dose ETRA, and then maybe DEXA can be helpful.
Yeah, so start low dose ETRA and set up with the ETRA gradually. So first start with 8 years. Many protocols, many institutions do that also. And do we recommend getting dexamethasone? I think for high risk we are doing it. For low risk we are not doing. Any comments on by anybody? For high risk APM we are adding dexa.
We have Dr. Raquel here joined. We can ask for her opinion how they are doing it.
Yeah. So, ma'am, do you want to comment on this? For dexamethasone, do you do prophylactically or not to APML patients?
To the extreme of age, like the patient being discussed is beyond 80 years of age.
Okay, so fine.
So the last query that the take-home message is what in these frail patients more than 75-year-old and more than 85 years, then who are more prone to go into the differentiation syndrome, the therapy should be given or should not be given, sir?
I didn't get you. What did you say?
Sir, in these more than 75-year-old or more than 85-year-old patients, who are more prone to get into the differentiation syndromes, so the therapy should be given in these cases. Like you have given, you should not have given the therapy to the patient, or what is the take-home message, sir?
No, it's not about therapy. We must be really cautious about it. You know, there should be a matter of caution that this patient can go into differentiation syndrome. Very high chance of going into this. So if the patient has got a high risk, elderly patients who are more than 75 years of age, they will get very high chance of differentiation syndrome. So we must be very much, they should be monitored very closely. The therapy has to be given. That is, by law, we need to give the therapy. But the monitoring should be very close monitoring.
Okay.
So very strict weight checkup. Every daily weight gain is there or not. Whether there is any component of ascites, any component of purification, that should be closely monitored in the rounds daily. Morning, evening rounds, because close monitoring is required.
Right.
Well, so we have finished with the first part, and I must thank Dr. Priyanka Srivastava to deliver an extremely good lecture. And what a wonderful question answer session we had with Dr. Priyanka Srivastava. And now we'll go with our
Dr.
second.
Amit.
Thank you so much. And now our second guest speaker from Madrid, Spain has just joined, Dr. Raquel D. Paz. We already introduced you, ma'am, and she's going to lecture us on ASH updates on MDS. Over to you, ma'am. You can present your presentation.
Okay. Okay. You can see my presentation, okay?
Yes, we can see. Please go ahead.
Thank you so much. Dear all colleagues from India, it's a pleasure for me to meet with you and to discuss the last developments from us regarding myelodysplastic syndrome. Over the next few minutes, I will be discussing the last developments in high and low risk MDS syndromes, and it's the outline I will be following through my presentation. First in high risk, and then in low risk. Since the publication of the Verona study, a phase 3 trial designed to compare treatment with venetoclax azacitidine, which show an overall survival of 22 months with azacitidine in monotherapy, which showed 21 months with no significant difference. Many research have sought to identify a subgroup of patients in who a small benefit from the combination venetoclax and azacitidine might be observed. The first to do was Dr. Garcia Manero from MD Anderson Cancer Center in Houston. He presented an oral abstract at the ASH meeting on the results of the secondary endpoint of the Verona study. In this study, a total of 590 patients were included, with a median age of 72 years old. The overall response rate was significantly higher in the Benaza group in the combination. The combination was include complete response, partial response, and complete bone marrow response, and was significantly higher in the combination venetoclax azacitidine 67% of the patients than in the ASA only 57%. This advantage it was principally in younger patients, less than 75-year-old, and those with more than 5% blast, with more aggressive disease, and those with mutation in TP53, with the hazard ratio in this group was 1.064, and in patients with molecular alteration like ASXL1 and RUNX1. The author concludes that the favorable trends in these specific subgroups suggesting that certain patients may benefit from this regimen. The second study presented by Dr. Uma Borate from Ohio University in the USA is a phase 2 trial designed to assess the clinical efficacy of the combination venetoclax and azacitidine in patients with therapy-related myelodysplastic syndrome. Therapy-related myelodysplastic syndrome accounts 10-20% of cases and is characterized by a complex karyotype, a specific molecular alteration, often TP53, and a very poor prognosis. This subgroup of patients are excluded from the majority of clinical trials and also the Verona study. In this study, 30% were included. Finally, only 23 patients were analyzed. Males was 70%. Median age was 60 years old. TP53 mutations were present in 83% of patients, and 81% had a complex karyotype. The overall response rate was more than 50%, 56% of patients, with 7 patients achieved complete response and 6 hematological improvement. The median duration of the response was around the year, was 12.7 months. The median overall survival was 10 months and 40 months for the responders. Dr. Uma Borate concluded, for therapy-related MDS patients, no other standard treatment with no other standard treatment options, venetoclax plus azacitidine may be a available strategy. The following study was presented by Guru Subramanian from Wisconsin, who outlined a multi-centric retrospective study conducted in 19 academic centers in the US to compare treatment azacitidine venetoclax versus treatment with hypomethylating agent immunotherapy. The study included 1,198 patients with intermediate to very high risk MDS. 313 received the combination hypomethylating agent plus venetoclax, and 885 received only monotherapy. Median age was 70 years. 27% was therapy-related MDS, and 34% presented TP53 mutations. Treatment with venetoclax plus azacitidine doubled the overall survival response with a rate 81%, compared with monotherapy 39%. Complete remission was 70%, compared with 9.7% with hypomethylating agent. Bone marrow remission was in more than 50% of patients, with 56% with the combination, compared with 14% with the hypomethylating agent. The authors recommended prospective study be conducted to evaluate the benefits the combination treatment in specific subgroups of patients with high-risk MDS. The following study, presented by Amer Fidan from the University of Yale, was a phase 1/2 BEXMAT trial. It's a study designed to determine the efficacy and conduct molecular and translational analysis of the high-risk myelodysplastic syndromes with TP53 mutation, treatment with bexmarilimab plus azacitidine. 53 patients, of whom 21 were treatment naive, and 32 have resistant or relapsed to treatment previously for MDS. The overall response rate was 78% in the TP53 mutation subgroup and 91% in the wild-type TP53 subgroup for previously untreated patients. And for patients with received previously treatment with other treatments and was refractory or relapsed, 46% in the TP53 mutation achieved response, and 74% in the wild-type subgroup. Overall survival in patients exceed 1 year, although it was lower in mid and TP53 mutation subgroup. Favorable immune activation was observed in the bone marrow driven by cytogenetic CD8 lymphocytes and the author conclude that the combination of bexmarilimab and azacitidine showed promising activity and suggested potential for controlling immune dysfunction in high-risk MDS and specific TP53 mutation. The last presentation about high-risk MDS was communicated by Alex Bataller from MD Anderson Cancer Center in Houston. He presented the updated results of the phase 2 trial, which involved the combination of the decitabine oral at dose of 100 milligrams for 5 days, plus venetoclax at the conventional doses 400 milligrams for 14 days. 68 patients with high-risk myelodysplastic syndromes and chronic myelomonocytic leukemia participate. The median age was 70-year-1, with 70% being men. 45% achieved complete remission. Median overall survival of 30 months and after 2 years overall was more than 50%. Less for patients with TP53 mutation, only 17 months. Event-free survival was 21 months. Myelosuppression was an expected effect of the combination, and 82% of patients required a dose reduction of venetoclax in the subsequent cycles. The authors conclude the oral combination of the decitabine oral and venetoclax is feasible and well tolerated for high-risk MDS and chronic myelomonocytic chronic. Now, in low-risk myelodysplastic syndromes, Dr. Valeria Santini presented the long-term follow-up results from the COMMANDS study, a phase 3 trial comparing luspatercept and epoetin alpha in transfusion-dependent patients with low-risk MDS. In this study, patients were randomized in 2 groups. One that received luspatercept at its standard dose, 1 milligram per kilogram every 3 weeks, with adjusted at the maximum dose at 1.75 milligrams per kilogram, versus another group that received epoetin alpha at the standard dose every week. After a median follow-up of 30 months, luspatercept demonstrated a sustained and durable response. A median accumulative duration of the all episodes of independent transfusion more than 12 weeks was 154.7 weeks with luspatercept compared with 91.1 weeks with erythropoietin agents. The benefit of luspatercept was maintained across various predefined subgroups, being greater for patients with higher hemoglobin levels, greater for patients with ring sideroblasts, greater for patients with low transfusion dependence, and greater for patients with low serum APOL levels. Dr. Valeria Santini concluded that this long-term follow-up analysis support is used as the treatment for choice for anemia in transfusion-dependent patients with low-risk MDS who had not previously received erythropoietin agents. The next study in low-risk MDS was presented with Amer Zeidan from Yale University. This is a phase 3B trial, the name Maxilus, designed to evaluate the efficacy and safety of luspatercept from the starting dose at the maximum dose, 1.75 milligrams per kilogram, in patients with low-risk myelodysplastic syndromes. In this study, patients were divided in two cohorts. The first comprising patients who were refractory to or intolerant of erythropoietin-stimulating agents, and the second include patients who had not previously received ESAs. The patients was evaluated in ESA naives and ESA refractory or relapse. ESA naive patients transfusion independence achieved more than 8 weeks was achieved in 73% of patients on equal or superior measure to 12 weeks in 70%. Better for patients with low serum APO levels that respond at the 85%. For ESA-resistant refractory or intolerance patients, 75% achieve more than 8 weeks, 45% achieve more 12 weeks. This dose was well tolerated with no thromboembolic events or progression to AML was observed. And Mercy then conclude, starting luspatercept directly at the maximum dose is safe and effective, especially in ESA-naive patients who dose with low EPO levels, and it works in ring sideroblast negative patients who are considered more difficult population to treat. The next presentation was given by Dr. Garcia Manero from MD Anderson Cancer Center in Houston, who outlined the phase 2 trial, decitabine oral, designed to determine the safety and efficacy and pharmacokinetic of different doses of decitabine. In this case, in patients with low-risk MDS. In phase 1, low-dose regimen at 10 milligrams of oral decitabine for 5 days was identified as the most suitable, and in the phase 2, this regimen was compared with the standard dose regimen, 35 milligrams or only 3 days. A total of 81 patients were treated with a median follow-up of 29 months. Transfusion independence higher than 56 days was achieved in 52% of patients with low dose and 37 with a standard dose. This difference is secondary to the safety profile of the low dose. Transfusion independent measure than 112 days was achieved in 47% with low dose and 20% with standard dose. The author conclude low dose of the oral decitabine regimen saw high and durable efficacy rate with a superior safety and tolerability profile, suggesting that this regimen could be an optimal option for patients with low-risk MDS. Another important presentation was the results of the phase 2 trial with elritercept. Elritercept is a fusion protein designed to block specific ligands to TGB family with the aim of improving erythropoiesis. This presentation was given for Dr. Chi and present the results of the efficacy and the safety in patients with lower risk myelodysplastic syndromes with transfusion dependence. 78 patients with SF3B1 mutated, 64% with the recommended dose 3.75 milligrams per kilogram, with the median exposure was near a year. Independent transfusion more than 8 weeks was 38.5%. Independent transfusion more than 4 weeks was 26.9%. Durable response was median duration 110 weeks. The author conclude elritercept demonstrate rapid and durable response in low risk MDS in transfusion dependence, but this data should be confirmed in ongoing phase 3 trial renew. And in conclusions, the combination of venetoclax azacitidine suggested a possible clinical benefit in certain patient subgroup, but this regimen must be confirmed in prospective studies. Bexmarilimab and azacitidine is another combination that shows promising activity in suggested potential for improvement in immunodysfunction in high-risk MDS and TP53 mutations. Decitabine and venetoclax is a feasible, well-tolerated options, and so a high risk rate in high-risk MDS and CMML. In low-risk MDS, luspatercept demonstrates durable and sustained response, which will support in its use as the treatment of choice in first-line low-risk MDS and transfusion dependence. Luspatercept and high-risk starting dose is safe and effective, especially in naive and with low EPO levels, and ring sideroblasts positive and also ring sideroblasts negative. This population more difficult to treatment with other options. Low dose of decitabine or elritercept could be optimal options for low-risk MDS, but need to be confirmed in the phase 3 trials. Thank you so much.
Thank you so much. बहुत बहुत धन्यवाद. Great talk, and you've almost covered everything from the ASH update 2025. And I now request all discussants to please put the hand raise signs so we can start a question session with our guest speaker. Yes, Dr. Satish Kumar, your question.
You're mute, Satish.
Oh, so sorry. So sorry. Thank you so much for the update, ASH update. I had a couple of questions. In low-risk MDS, if the patient has received erythropoietin, he is not erythropoietin naive. You did show in the trial that even in refractory patients to erythropoietin, giving luspatercept helped. So what percentage of patients does it help, and how long should we give luspatercept till we say he or she is refractory to luspatercept?
Yes, we have experience with luspatercept in patients that received previously erythropoietin agents. In approximately, my experience is the long duration of the luspatercept is approximately 1 year and a half. But you can increase the dose, okay? But when the hemoglobin decrease with luspatercept, in my experience, associate again EPO increase the hemoglobin, in my experience. Again, when you see response with luspatercept, and you can increase the dose if you want to increase the hemoglobin. But if the hemoglobin decrease and you achieve the maximum dose of luspatercept, associate again erythropoietin agents, especially in patients with previously was refractory with EPO, because the indication in this moment is in EPO refractory, is not in EPO naive. I don't know in India, but in Spain is in EPO refractory, the indication, and in transfusion dependent, non in first line. You can associate both and increase again the hemoglobin. In my experience, is very, very good. And it's very important to achieve the maximum dose of luspatercept, no 1.0 milligram per kilogram. You can increase the dose if the tolerance is well, okay, if the tolerance is well, and if in one moment the patient decrease the hemoglobin, associate erythropoietin agents, the combination, independent if the patient was refractory previously to EPO, the association improve the response of luspatercept, because maybe it's because it's different mechanism of action, and to join both is better. Maybe not at the beginning, but if the hemoglobin decrease during the treatment with luspatercept, associate EPO during the treatment with luspatercept, long the duration the luspatercept. In my experience, 1 year or 1 year and a half is the duration. Sometimes 2 years, it depends of the patients. It depends of the patients not receive or receive very, very low transfusion at the beginning. For patients with high risk transfusion dependent, the response is very low or sometimes is not respond
Right.
to
Thank you,
luspatercept.
Dr. Rekha. Another question is in high risk MDS. So which are the subset of patients where you prefer as and when? We don't have oral decitabine as of now in India, but which subset of patients do you prefer as a when or any hypomethylating agents alone in high risk MDS without excessive blasts?
For us, it's the same. We don't have the decitabine oral in Spain. We don't have approved the combination with azacitidine in venetoclax in MDS. We don't have approved. It's the same of you. But this study for patients with high risk of with burden disease near to acute leukemia, especially for patients to go to transplant, the combination is possible to obtain benefit, especially in younger patients, in patients with more than 50% of blasts near to acute leukemia, 15 or 18% of blasts. You can reduce the burden disease previously to transplant with the combination. But again, it's the same of you. We don't have approved the combination for MDS. The treatment for MDS is azacitidine alone. But this study recommending this combination, especially in the study of the 19 centers in the US, the real world in US with more than 1,000 patients treatment, the combination demonstrate superiority to the azacitidine alone. But for MDS in Spain is the same. Is the standard treatment for all population of MDS.
One last question. Where do you recommend hypomethylating agents in low risk MDS? Do you use in clinical practice as I said in any of the set of low risk?
No. We don't have approved for low MDS, only for high risk MDS. It's only for cases with no response to EPO, luspatercept. We do the imetelstat clinical trial. We do other treatments in clinical trial. When you use all options for treatment, you can use hypomethylating agents for low risk MDS. But the results is not good. Is not the recommendation. Is not approved for low risk MDS, and the experience, in my experience, is not good.
Thank you so much.
Thank you.
Thank you, Dr. Satish Kumar. Dr. Babita Sodi, your question, please. You're muted, Dr. Babita.
Thanks for the nice update, Dr. Raquel, that MDS is the very heterogeneous entity. In the last decade, the colorectal carcinoma was said to be the most heterogeneous. And for the centuries together, the virus is said to be the very heterogeneous and the most heterogeneous because it can make the millions of copies. But in our understanding, the MDS is the most heterogeneous and it can make more copies than the virus itself. Having said that, the pathogenesis on the top of it, when it is not known much, and when it has a complex karyotype, every type of MDS, my query to Dr. Raquel is that what are the epigenetic factors vis-a-vis, in addition to the genetic factors, vis-a-vis the transcription factors, RNA splicing and the DNA methylation and the histone modifications responsible for this heterogeneity, and especially with special reference to when the silencing of these genes is responsible for this, Dr. Raquel?
It's a question related to therapy related to MDS. Yes. It's a population especially very bad and no treatment for TP53 mutation. In general, for example, Dr. Garcia Manero recommended recommended, for example, in this case, is the combination, because we don't have options for this kind of treatment. It's a very, very bad population. Is excluded of the all clinical trials, and the combination venetoclax azacitidine, because it's the treatment selected for AML patients, maybe will be the best treatment, the best option for therapy-related MDS. But it's a population very, very bad with a very poor survival.
Any other question, Dr. Babita?
Sir, my question was different slightly. That I just asked that what are the epigenetic factors, especially the DNase methylation and the histone acetylation? Is the silencing of the gene, sir? If you can answer this query, that is there silencing of the gene is responsible for the most heterogeneity of the MDS? This is my query, sir. Heterogeneity of the MDS.
So what her question is regarding the MDS pathogenesis part. What she's trying to say is whether the epigenetic mechanism for MDS, that is DNA hypermethylation or hypomethylation, whether that is responsible for the clinical presentation of MDS, which is so heterogeneous in most of the patients. Actually, some patients may have a varied presentation. Some patient may be excessive transmission dependent. Some patient may not be transmission dependent. So whether this epigenetic variations, does there any role in the clinical heterogeneity in the presentation of the patients of MDS?
I don't know about the pathogenics because I am clinical, and in my experience, for low risk MDS, in this moment in Spain we have the same like you, only azacitidine, and this is the hypomethylating agent. Maybe is the best for the mechanism of myelodysplastic syndromes, but in the myelodysplastic syndromes, I'm sure I am a component of inflammatory in the bone marrow, because it's associated a rheumatology disease and other inflammatory disease. Maybe we have continue associate different treatments to hypomethylating agents to better response. But for the moment, all treatments compared with or associated with azacitidine fail. Azacitidine plus pevonidostat failed. Azacitidine plus magrolimab failed. Azacitidine plus sabatolimab failed. Azacitidine plus borinostat failed. In this moment, azacitidine plus venetoclax also is very, very few the benefit. The mechanism in general, I don't know, is very difficult. It's very difficult.
Thank you.
Thank you.
Dr. Nikhil Kumar, your question.
Wonderful presentation. Thoroughly enjoyed it. Dr. Satish asked most of what I wanted to know, but a couple of questions from my end. In MDS patients on luspatercept, once they respond well, the hemoglobin is more than 11. How do you titrate the dose? Do you reduce the dose or do you increase the frequency of luspatercept?
In my experience, if the hemoglobin is 11, for example, we maintain the dose. We not reduce the dose and no space the dose, in my experience. And the hemoglobin level maintain. We have patients with other imetelstat, for example, in clinical trials, and achieve 12 of hemoglobin or 13 of hemoglobin, and it's the same with lenalidomide for del5Q. You maintain the dose. We no reduce. The recommendation is for the moment not reduce the dose, because a long time the duration of the response is not very, very, very long. For the moment, if you achieve a hemoglobin of 11, for example, I maintain the dose, the same dose, not reduce the dose, and no space the dose.
So there's
in
no
my
particular cutoff of hemoglobin above which you would say you would hold the dose or increase the frequency. If it is 12, 13 on a patient on luspatercept, would you recommend continuing the same dose or reducing the frequency?
is well tolerated and the hemoglobin is 12, for example, is good hemoglobin, but sometimes it's not easy to achieve 12 hemoglobin in MDS patients. And in my experience, maintain the dose and not reduce the dose, and not space the dose.
The reason why I put across this question was in our experience, we have had a few patients who have responded beautifully. Even with 2 or 3 doses of luspatercept, the hemoglobin has reached 11, 12. And more than out of standard recommendation, because the drug is expensive, very often we have had to increase the frequency. Instead of once in 3 weeks, we would increase it to once in 4 or 5 weeks. And we have a few patients who have been maintaining hemoglobin more than 10 on this dose. So that's the reason why I put across that question.
Yes, I know. It's expensive. I know. If you space the dose or reduce the dose and maintain hemoglobin, is okay. But in NDS patients, first, it's difficult to achieve hemoglobins near 12. It's very difficult. Sometimes increase the hemoglobin or achieve only independent transfusion and maintain the hemoglobin in 9 or in 10. But yes, it's expensive. And if you can reduce the dose a little bit or spade, for me it's the same, reduce a little bit or spade 1 week or 2 weeks, it's okay. You can try, and it's good for the patient, it's good for the health, the economy.
And Dr. Amit, what is your practice? Would like to know if you have a similar experience or do you follow a fixed schedule?
Of luspatercept?
Yes.
So I will give a very practical experience of my patients, because till now I would have treated around 15 patients with luspatercept. It was a 50% response to my knowledge till date. What exactly has been written, I don't know whether that is being followed or not. But to my knowledge, only 50% of patients did respond to luspatercept who failed EPO, basically. So, and those patients who had a very high EPO level of more than 500 also, when started the patient on luspatercept, the many patients basically, as supposed to be, they must respond by 8 weeks or by 12 weeks. Many patients did not respond, even at the highest dose also
Yes.
recommended. So I think that is based on individual variations. There are some patients who responded. About 50% of patients they responded, but what the document doesn't say, that the data doesn't say it. But to best of my knowledge, only 50% of the patients did respond with luspatercept in case of low risk MDS. In high risk MDS, there was no point of giving luspatercept at all. But in low risk MDS, definitely only 50% of patients did respond actually. But 50% of patients whatsoever, EPO failed, high EPO level, when they were given already prior erythropoietin given, they did not respond with luspatercept even at the higher dose when we were escalating the dose also. Those 50% of the patients who responded basically were at the minimum dose level, only they responded. They were not able to escalate to the highest dose. They did very well with the minimum dose level only. So there was no question of escalating the dose. So those patients who are already on luspatercept, they are maintaining on luspatercept at the minimum standard dose level. There was no question of increasing the dose for those patients. And those patients who did not respond, they did not respond with increasing the dose
also. And in those patients who responded, you could never really de-escalate or increase the frequency too. You have never had this thing where you can
because
reduce the
financial
dose.
problem is there. One thing, because our patients do have a financial problem, number one. And if the patient, what we are thinking is, if the patient not responding with increasing dose or increasing the frequency, will that matter? Basically, that was a big question. And I think that has not favored to any of my patients. So those patients who have responded with the first dose only.
Fair enough. And my second question is with respect to venetoclax. You mentioned only very specific subgroups, young patients who are transplant eligible as a bridge to transplant we can use. My question is, does the mutation profile of MDS patients also play a role when you decide whether to add venetoclax to azacitidine? Because based on our AML experience, we know certain mutation profile responds very well to the combination of hypomethylating agents with venetoclax and some of them don't. Does it hold true for MDS also? In a high-risk MDS who's transplant ineligible, would the mutation profile play a role in deciding whether we need to add venetoclax versus go ahead with single agent azacitidine?
This is only the conclusion of this study. In my experience, it's not possible in combination because it's not approved in Spain. In Spain, it's only approved for MDS, for high-risk MDS, azacitidine alone, including patients with go to allogenic stem cell transplant. Sometimes you can negotiate with the pharmacy if you have a patient, a younger patient, and go to transplant, adding for example, in the second cycle, adding the venetoclax, because with azacitidine alone, see benefit about, for example, cytopenias, or maintain the same percent of blast, and you reduce the burden disease to go to allogenic stem cell transplant. But it's difficult because it's not approved, and it's difficult to negotiate with the pharmacy. I show the results of clinical trials, the Verona study, the second endpoint, and the real life in USA. But in the real life, maybe for you and for me, it's not possible the combination in high risk MDS. No, I don't know in the future, but talking about with the laboratory, with ABI, about the combination and the improvement in the future, maybe not for MDS, only for AM.
Okay, thank you. For us, fortunately, that approval part doesn't come into the picture. We can always give venetoclax for a subset of patients whom we feel can benefit from the drug. We don't necessarily have to wait for an approval from an insurance agency or the pharmacy. So that way, the practice is a little different in India. So that's why I put across that question.
Yeah, for us, it's impossible. Maybe I think it's a little bit number of patients we can achieve benefit, especially previously to go to transplant. But it depends of the mutation of this kind of patient. For example, with TP53 mutation, if you achieve very good response previously to transplant, with this mutation, maybe after transplant, patient relapse again. We have a population with very, very poor prognosis, and independent of you adding a venetoclax to azacitidine previous to transplant.
Thank you.
Thank you, Dr. Nikhil Kumar. Any other question anybody has? Well, so in that case, this brings to the end of our second also. Thank you so much for your wonderful lecture. That was a wonderful and great update by you, and a very well covered topic, and what a wonderful discussion we had with you. Thank you so much. And I now request Mr. Archit Patnakar from INTAS to go for final vote of thanks.
Yeah.
Thank you so much.
So on behalf of INTAS Pharmaceuticals, it is my privilege to extend our sincere thanks to everyone from Mumbai Hematology Group. And we are deeply grateful to Professor and Program Director Dr. MB Agarwal sir, and our eminent guest speakers, Dr. Priyanka Srivastav and Dr. Rakul Dipas, and Honorable Chief Guest, Dr. Shilpi Saxena, and our program moderator, Dr. Amut Khurana sir. So my sincere thanks to all of you, and a special thanks to all the delegates for their participations. So we are honored to support such impactful academic initiatives and look forward to continued collaboration. Thank you so much. Have a wonderful day. Thank you.
Thank you so much. Thank you for the invitation.
Thank you.
Thank you all.
Thank you all.